Okay, so as Dr. Troxler just said, I'm going to be presenting on the intersection of TBIs and opioid use disorder. And I will be speaking broadly about literature, but then more specifically to some research that Meredith and I have conducted in Johnson City. I don't have any financial conflicts of interest to disclose. And objectives for today would be to think about the common pathways that TBI and OUD are related. So the kind of trajectory and relation between the two. Also think through some cognitive sequelae of TBIs that might be relevant to think about when you're treating somebody who has OUD. And then thinking specifically about those adaptations and how you might best help somebody who you're providing care for that has a history of a TBI. So first, I want to super briefly talk about what exactly I mean by traumatic brain injuries, because there is a little bit of disagreement about what exactly is considered one. For instance, some people don't consider concussions TBIs and some people do, but for the purposes of the research that I'll be talking about today, concussions do count as mild traumatic brain injuries. And it's really anything external that causes a disruption to brain functioning. And there's two kinds. So closed head injuries, which is a kind of head injury that just doesn't impact or doesn't go through the skull and the meninges. And then a penetrating head injury, which does. And that's definitely a less common form of a brain injury. The most common causes of TBIs would be things like motor vehicle accidents, falls, especially for your older adults, and being struck by an object, like thinking about like playing sports and getting hit by a baseball bat or that kind of thing. And there's a really big span of what exactly a TBI can look like. So a more mild TBI could be something like not even losing consciousness, just feeling kind of, dazed and out of it for a little bit, and not really having any long-term repercussions from that, compared to some of the more severe TBIs, which can produce like death and, serious long-term kind of disability or coma. So the outcomes are very variable and really depend on the severity of the illness or the severity of the injury combined with other factors, such as the ones listed here. So Dr. Corrigan from Ohio State University has done a lot of research on TBIs and substance use. And I liked this chart because it gives you some things to consider if you're working with somebody who has a history of TBI and what you might look for. If you're thinking about like, really, does this person's history, is it likely to really impact my work with them today? So things to consider would be worst. What's the worst TBI they've ever had? If it's moderate or severe, they're more likely to have long-term kind of adverse outcomes. The next would be first. So if it's happened before the age of 20. Multiple TBIs, but especially if they've happened before the prior TBI had a chance to fully heal. Those would be most likely to produce cognitive kind of changes. Recent injuries, especially if they were more of that moderate to severe, you can expect even longer kind of course of symptoms compared to mild ones. And then other sources. So just thinking about what comorbidities might be relevant. For instance, if somebody has like a baseline kind of neurodevelopmental disorder or another injury or something else that might just kind of cumulatively affect the person's cognition. So, and when we're really talking about these cognitive changes and other outcomes that you can expect to see following a TBI, there's like what people consider to be the thumbprint of a TBI, which is this dysexecutive functioning. So really, regardless of like the point of injury, you can expect to see more frontal kind of dysfunction just because of the way that the brain is kind of situated in the skull and these kind of like bony protrusions that just impact the frontal lobe in particular. So for most people, you can expect to see things like difficulty with organization and planning, disinhibition, more difficulty with impulse control, just poor attention and concentration. Those would be kind of like hallmark symptoms of a TBI. But then there can also be other changes that are more specific to the actual like kind of locus of the injury. And especially if you're thinking again about like a penetrating head injury. TBIs are also associated with increased psychological symptoms, PTSD being one of the most common ones, which makes sense just given the fact that everybody who has a TBI has had some sort of an injury, and that could have been traumatic in nature. But also increased rates of anxiety, depression, suicide, both completion and just ideation in general. There's also increased rates of chronic pain, and that's related both to the TBI, but then also most people don't just hit their head and nothing else. Generally, like there's other kind of physical injuries that have been sustained at the time. And of course, the purpose of this talk, which is substance use. And I should say that a lot of the research to date has really focused on alcohol and TBIs, I think mostly just related to the role of alcohol in car accidents and how a lot of those have resulted in TBIs. But I hopefully will convince everyone that we should also be thinking about them in relation to opioids. And I'm not at all the only one who has been kind of thinking about this recently. There's been definitely an increase in research on this topic. A lot of it, though, has been more like kind of hypotheses and just kind of proposed like relations between the two, but there hasn't been a lot to date that has really investigated like the comorbidities and kind of trajectory between the two. And everyone will have to forgive that I'm not very good at graphic design, but hopefully this will outline the three kind of trajectories that I think you can expect to see between opioid use disorder and TBI. So the first reason that we think that they might be connected is because of just underlying kind of tendencies. So maybe somebody who just tends to be kind of a risk taker, kind of impulsive, really likes new things, like is really novelty seeking. Maybe they're just more likely to experiment with drugs, and maybe they're more likely to engage in like, snowboarding or like other sort of riskier behaviors that could also result in a TBI. It could also be that opioid use disorder could lead to an increase of TBIs. And this, so far, I think in the literature has mostly been linked through overdoses and people who had fallen during an overdose, but also just thinking about like acute kind of intoxication or acute effects of opioids. You can expect to see motor dysfunction, and you might just be more likely to have accidents or attacks or falls. So that could be one way that people who use opioids would be more likely to have TBIs. And then the last way would be that people who have traumatic brain injuries are more likely to develop opioid use disorder. And there's a couple different mechanisms that I think could explain this. The first would be chronic pain. So I already mentioned that TBIs are likely to result in chronic pain. And that is a big reason that, number one, people, I forgot the rate, but it's over 60% of people who have had a TBI are treated using opioids in the hospital. So there's just this common kind of introduction of opioids for people who are having TBIs and for treatment of long-term pain. And then there's also the increased rates of PTSD, anxiety, depression, which we know, of course, are associated with increased rates of substance use disorders. And then the last piece, which I'm not super familiar with, but I have references on my reference page if this is something that's of interest. But it's more about just the actual neurological changes that happen at a TBI or during a TBI, like the axonal like shearing and the neurochemical changes might just lead people to be more susceptible to developing an opioid use disorder. But all of this is really kind of hypothetical at this point, not something that a ton of research has been done on, which was in part why Meredith and I wanted to do the study that I'm about to talk about. So our main research questions were just, first of all, what's even the prevalence of TBI among persons with opioid use disorder, and specifically those who are seeking treatment for opioid use disorder? The second is, if there are TBIs among this population, why should we care? So are there any behavioral differences? Is there anything notable about their presentation that might be helpful to kind of inform treatment? And then the last piece is, if so, how can we make sure that we're providing sufficient care for those persons that really accommodates and is adapted for their presentation? So to study this, Meredith and I organized a research study at 2 different addiction medicine clinics in Johnson City. And we just basically asked people about their TBI history, psychological variables, and demographic information. And then we also did a systematic review of the available literature on substance use disorder treatment for persons who have a TBI. So I'm going to launch into our main results. So the first finding that we had of a little over 150, I think it was 158 people that we ended up getting collecting data from. And all of those had confirmed opioid use disorder if they were in treatment. And we found that almost half, so like 48% of them reported at least one TBI in their lifetime, which actually wasn't really that surprising. That's very much on par with TBIs among people who were seeking treatment for alcohol use disorder. And then also it's right around the range of rates of TBI among people who've experienced homelessness or incarceration. So there is kind of well evidenced a high rate of TBIs among people who are kind of vulnerable. So this was on par with other estimates. Then we asked about the length of loss of consciousness. So this is kind of like a nice rough and dirty way of estimating the severity of the injury, because unfortunately we don't have things like neuroimaging or ED reports or anything like that. But this is shown to be a pretty reliable indicator of severity. And we found that most of them were going to be probably in this mild range, with very few people having more of the moderate or severe kind of TBIs. Then, like I mentioned, we just wanted to see, just to gain better understanding of what exactly the patients who had TBIs looked like and if they were any different than patients who didn't. And we found that in terms of demographics, actually, they were very similar. So no differences here. And the only difference here was just related to mental health diagnoses. So persons who had TBIs were more likely to say that they had been diagnosed with a mental health disorder at some point, which I think could be due to actual higher incidence rates, but it also could be attributed to just like more contact, I think, with the healthcare system. Okay, so we wanted to ask about the timeline because, like I mentioned, a lot of different research had really hypothesized like different sort of trajectories where one precipitated the other. So we wanted to really identify if there was any common pathway between the two. And so we found that for most participants, they had had a TBI before they had ever initiated opioid use, which also it seems kind of obvious when you say it because you're like, well, of course, people have so many more opportunities, like since the day they were born to have incurred a TBI, but the opportunity for opioid use is more restricted. So it makes sense, and it was expected that people would have more often had a TBI before using opioids. We also wanted to ask about the source of the opioid that's first used, because a lot of people had proposed that maybe it's because people are being treated for the TBI and they're being administered opioids during that time, and maybe that's just like a vulnerable period. And we found that there weren't any differences between the source of the opioid. However, people who had had a TBI were more likely to be prescribed an opioid at some point by a medical professional. And we were careful to exclude like medications for opioid use disorder. So not like methadone or buprenorphine, but separately, they had been prescribed an opioid. And we also wanted to capture the risk profile of participants who had had a TBI. And one of the things that we were really interested in was polysubstance use and also risk of overdose. So the shaded boxes are the ones that were statistically different between the groups, with people who have had a TBI were more likely to have also reported using sedatives, cocaine, amphetamines, and fentanyl non-medically. And they were also more likely to have had an overdose at any point. And you can see the difference between the 40% and 19%, so almost like a double increase. And generally, we don't really think of TBIs as being like dichotomous. As I was saying, there's a really broad kind of span of what you can expect in terms of outcomes. So we wanted to make sure that we were capturing that as well. So we wanted to look at the number of TBIs, and we wanted to look again at that risk profile. So the ROA stands for route of administration of opioids. Just knowing that something like taking capsules is less risky than something like intravenous use, just in terms of risk of like infection and HIV. And we found that there's a higher number of TBIs on average for people who are in this high-risk group as compared to those who are using opioids in a less risky way. We also found that people who were in the moderate to severe TBI group were likely to have a younger age of first opioid use compared to the other groups here. And then the last thing that we wanted to look at for this study was related to comorbidities. So I wanted to see, were there higher incidence rates of other mental health comorbidities that might be relevant to think about as you're engaging in treatment with someone. And we found that rates of depression and PTSD were comparable between people who've had TBIs and who hadn't, which was kind of surprising, just given those links are very kind of well established in the literature. But we found that they had higher rates of just overall anxiety and also higher rates of pain per the GAD-7 and the BPI. So the last part of our study was to do a systematic review. So we looked at 10 different articles that had implemented some form of treatment for substance use disorder among people who had had a TBI. And we found that across the board, studies the treatment modalities were effective. Motivational interviewing or enhancement had mixed effects, though. There was a couple of studies that had shown that maybe they weren't so effective. Comprehensive TBI services had support. Prolonged exposure, which you might know is not something that we really give for substance use. That's a PTSD treatment. But the study that had used it had substance use as an outcome variable, so we did include it for this study. So that one also was effective, as was a screening and brief intervention just within a hospital setting. So all these were effective in reducing substance use among persons who had had a TBI, which was encouraging. And then they also listed some different adaptations that they'd had for treatment as usual for this group. There weren't any studies that actually did like a real control experiment or really like analyze these all that well. So it's more qualitative information that they just provided. But the studies had used memory cues, so lots of like external aids for the things that they had talked about in sessions by like setting up more reminders, calling the participants and giving them like kind of follow-up prompts to engage in certain behaviors that they talked about during the sessions. They'd also used multiple modalities. So for instance, with patients with TBIs, they wouldn't have provided psychoeducation only orally. They also made like videos and had worksheets to hand out, and just wanted to repeat the information in using multiple modalities, but also over sessions. So studies had commented on just using more sessions than maybe would be typical, just to make sure that the person had, lots of time to really practice and repeat it in session with them. Some other studies had also used role plays and found that helpful. So for instance, thinking about like when your friend offers you a certain substance, how are you going to respond to that? And really doing lots of like hands-on, very practical kind of techniques in session. So across the studies, our main takeaways was that TBI is common among persons who are seeking treatment for opioid use disorder. And it is something that is pretty prevalent in our population, like almost half of participants had it. TBI most often precedes opioid use. And persons with TBI are more likely to receive an opioid prescription at any point. TBIs also corresponded with increased rates of overdose, riskier routes of administration, and other forms of substance use. But good news is that substance use disorder treatment is effective for persons with TBI using several different treatment modalities, and there are some accommodations to treatment as usual that might be helpful for them. And I have lots of references. I just wanted to point out the one here is the specific TBI questionnaire that we used, and it is free and accessible if anybody wanted to have that. But that was really everything, Dr. Truxler. I don't know if we want to have questions or if you want to use your case study.
Yeah, actually, if you want to just go ahead and advance, because is it on yours? Yep.
Oh,
that's okay. It's the one. I should have it. 1 second. I really, really, really enjoy.
I have it with the case. Do you not have it, Joyce?
I do. I just have to go digging in my emails to get it. So if you have it right at hand, but I can dig in my email too. Because it's in there. Dun, 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 dun. I can also just do it off the top of my head. But having the slide is.
I got it.
You got it? Perfect.
Yeah.
It's the very inside.
All right. Can you see it?
Yeah, I think
Yeah.
so. Yeah, you sharing? That's you sharing?
That's my share, yeah.
Okay, all right, because my screen just started doing crazy things. So, okay.
Can you see it, Hannah?
Okay. Yeah, that's good.
Okay, good. The rest of the world sees it too. I feel like I'm just having a very special connection with you right now, Meredith, and it's just me who sees it. So good. I'm glad everyone else can see it. So with this case, when we first started talking about giving you guys a presentation about opioid use disorder and traumatic brain injury and sort of that overlap there, immediately came to mind one of my long-term patients in clinic. I think I've been working with this individual 3-4 years now. It's actually, wow, it's been several years that I've been working with him. He's a 37-year-old white male who comes from one of our more rural counties, who has both opioid use disorder and stimulant use disorder and history of TBI. And when I sat down to kind of, go through his history, and I was thinking about his TBIs, and thinking about the ones that related to when he was like in his early 20s, motor vehicle collisions. And both of the car accidents, he was in a coma with both of them for days. One of them was like a propofol induced coma, because I think he was rather combative with that one, and so they snowed him basically. And then the second one, he was actually, I don't know if it was from edema or what, but that was not medically induced. So he had two very severe head injuries, non-penetrating. I don't think there was any skull fracture or anything like that, or any type of instrumentation that had to be done to relieve pressure. But as I was thinking about his case, I remember him telling me a story actually when he was a kid. He was exposed to substances starting at age 11 because he was in a rather abusive home environment. And one of the ways that his family entertained themselves was to give him drugs and just watch him go around messed up. They found it entertaining, unfortunately. And he also was physically abused, beaten by his father. And one of the, at least once, probably more often, he does recall having his head slammed against a concrete floor when he was under 20 years old. So he's actually had probably more than even the three that I list here, because he also would have a predilection for getting in fights. He had a lot of anger, and then you throw some stimulants on top of it, and he definitely had impulse control issues. So he was engaging in physical altercations as well. So this young man's brain has kind of been around the block several times and not treated very nicely. He also has underlying hydrocephalus. He was recently in the hospital with a seizure. It seems as though he had stopped taking a medication we were using as prophylaxis for migraines, topiramate, and had basically a withdrawal seizure from that, is what we're thinking may have happened. He's now on an anti-epileptic because of that seizure episode. But just to illustrate how complicated traumatic brain injury can be in some of our patients, he's a really very clear case of the TBI starting at a young age. He was in an environment where he was exposed to substances because of people using them around him, but also because they gave them to him at a young age. So all of this kind of went in to make a very interesting environment for a developing brain that went on and experienced even more trauma as a young adult. With this individual, we definitely see the executive functioning with him. He has impaired memory. Short-term memory is not great. Long-term is better. He'll often repeat portions of his story. We talk about how he has no filter. It's one of his endearing qualities. I really would rather he had not had this history and not have any endearing qualities. But when he tells you something, you're getting it all absolutely unfiltered. And if you blush easily, you may not want to be in the room with him alone for very long, because he's just going to tell you straight up exactly what he's feeling and thinking. But it actually makes it easier to work with him in many ways, because there is no doubt about what this individual has been doing, with whom he's been doing it, and how much he's been doing it. Stimulants have been very much a part of his life. And because of the brain injury and the stimulant use, we often find him to be scattered. It's very difficult to get him engaged and maintain momentum, that lack of traction, where we kind of see him putting one foot in front of the other, even one toe in front of the other, to sort of move forward. He was able to stop injecting substances, which was a huge breakthrough for him. We did treat him for hepatitis C. It was because of treating him for hepatitis C that he put down the needle, and very clearly states that's why he stopped using, and he didn't want to get hepatitis C again because we were able to cure him of it, and he didn't want to risk getting it again. So there are moments when he very clearly grasps the severity and the importance of the work he needs to do, and he is able to do it. But that scattered, some days are better than other days approach is very present with him. It's also influenced some of his personal choices. A relationship that he's been in until recently really seemed to play a big factor in him being kind of keyed up He was having his poor memory used against him, having money stolen from him from someone who's supposed to be his life partner, used and abused by this person emotionally. So they actually broke up, and that has allowed him to start putting his life together in a little bit different fashion than what it was before. And we've seen him actually stop using stimulants over the last 4 to 5 months. But that is in working with him for the last 3+ years, where every single urine drug screen and oral mouth swab have been positive for methamphetamine. And I think that's an important piece to highlight here, is that we continue to prescribe him his buprenorphine. We did not reduce his dose. He was not using illicit opioids, though he was continuing to use methamphetamine. We did not change his treatment plan related to his opioid use disorder, because he was adherent to that part of his treatment plan. But we continue to work with him, connect with him, provide him resources, short-term follow-up, really just work with him. Everyone in clinic has had a chance to get to know this patient, and work with him and help guide him ever so slowly forward. And I feel like this year he's had some really amazing breakthroughs with his ability to stop using stimulants. And that alone has really helped, I think, a lot of his cognition. Like I mentioned before, he does have migraines that are related to his traumatic brain injury. And he does have chronic pain as well. He has a fair amount of hardware in his back from the motor vehicle accidents, resulting in fractures in his vertebra and other issues in his spine that have resulted in the placement of hardware. He is on disability because of those things. And he actually is having to deal with navigating that really complicated system, where his disability is actually being threatened because of the toxic relationship that he just ended. Continues to seek him out and try and make his life difficult. And he was reported to the disability board for misuse of funds. And he's now having to go through an appeals process, which, as you can imagine, for somebody who's had the traumatic brain injury history he's had, navigating that system is hard anyway. But that's another way in which we're supporting him and helping him figure out appointments he needs to make, what he needs to put into his appeals, the paperwork that he needs to complete and turn in a timely manner. So our clinic does help support him in these endeavors, to just kind of help him stabilize and get his feet back under him as he rebuilds his life after this relationship has ended. But I think we all have great hopes for him. He's going to come out on the other side of this doing a lot better than where he was when we started with him. So with that, does anybody have questions about today's presentation, or have any similar cases with patients who have a traumatic brain injury? This gentleman's, he's had a lot of them. It's significant in the way in which it impacts his ability to engage in the world around him. He's definitely left a stamp on his personality and his ability to interact and engage with others. But he is, I tell you, to know him is to love him. He's a really amazing human being. But if there are any questions or thoughts or anything anybody wants to share. And thank you, Hannah. It was a lovely presentation. It's very interesting material.
Joyce, I just wanted to highlight how this is the perfect case for integrated addiction medicine. So many complicated comorbidities, and also such a great need for case management, for peer recovery. This would be a very difficult person to help, I think, if you weren't on such a large team. So it really does make the case for integrated care.
I agree. And I think that's part of why we've been able to keep him engaged in treatment. One thing about this individual is his degree of loyalty. It's like he's almost like a baby duck, like he imprints on you and you're his forever, forever. And so having multiple members of the team that he feels connected to and supported by, again, I do think is part of the success that he's had, because there are multiple members of the team. And he's also, in the beginning, it was very clear, like there was 1 or 2 of us. He's like, that's the only person I want to deal with. And the more time he spent with us, he imprinted on more and more and more members of the team. And so his support group just kept getting larger. And I think that acceptance that he experienced in our clinic really did help him follow through with some of his intentions. And he, like, that loyalty is deep. He's very much like, I can't use a needle again because I don't want to tell Dr. Troxler that she may have to treat me for hepatitis C. Like, there's a very black and white quality to his interactions. But he's also just again, like I said, to know him is to love him. We actually had Adrian join us. Adrian, if you don't mind unmuting and introducing, please.
Hi, I'm Adrian. I am the Meredith Ginley therapy intern at the ETSU Addiction Medicine Clinic.
Wonderful. Thank you for joining us, Adrian. Suzanne, how often are you guys identifying patients with TBI or recognizing that as part of making your treatment plans a little challenging?
Yeah, I haven't had very many that I've identified as being difficult with the treatment plan, but I have had several patients that have had head injuries, obviously. A lot of the lifestyles they're living as adults, in the streets and here, there, and everywhere. I've had a lot that have been assaulted multiple times. I would say I have one patient right now that he's a challenge, and it has played a factor. But other than that, I know there are quite a few that have had them, but as far as playing a factor in their treatment, not terribly many that I've seen. I did like hearing about your patient though. Very interesting case. I would enjoy working with him, I think, as well.
He's a trip. He's a trip. We get to do home visits with him because transportation is kind of, so he's had his license revoked and actually had to spend like 60 days in jail because he was driving on a revoked license. So we do home visits as part of his care. He gets telehealth home visits, and then like once a month he's driven into clinic by somebody so that he's not driving again and having to go back and finish. It's like 500 and some days he's going to have to go back if he gets picked up again.
Okay.
Yeah. So we, very much like meeting them where they are and what they can do. So going up and having home visits with them is always fun. Yeah. He's a trip. Like one time we did a home visit and he's just like, yeah, because I was walking around on the property. It's beautiful property. And it was during the summer and there were like blackberry bushes and one of his kids was showing me the blackberry bushes. And then she's like, that's Daddy's special plant. And I'm like, oh. He had a potted plant, a pot on the back side of his property. I'm like, we'll just go back down here then.
That's right. The tour is over.
It's okay. But yeah. He gets his pot from a dispensary now, and I'm like, you know what, if that's what we're doing, going over to Virginia and getting pot from a dispensary and not fentanyl laced pot from, Joe down on the corner and whatever else from him, and not using methamphetamine, we can make that work for right now.
Absolutely. I feel the same way about that.
Yeah. So it's really about meeting people where they are and what they're capable of and recognizing the limitations as they present and how they're unique patient to patient. And again, because he can get agitated, anger has definitely been a part of his affect and his interaction style, because he can get worked up easily. I feel like that's gotten better over the last year and a half. I do feel like he's had less methamphetamine use, and now that it's not part of the picture at all, that has greatly improved. But he is still a little bit of a hair trigger. But even right now, he talks about not feeling like he has to fight everybody. He went through a period where he needed to fight everybody for any reason that he could find.
One thing I will say is he's never been angry towards us or violent towards us at all. And so as Joyce says, you just can't get offended. It's nothing personal towards us. He loves us, but he does get worked up in the room.
Yeah.
I just want to also thank Hannah. Very, very well, said the relationship between the TBI, substance use, and also other psychiatric problem. We deal with lots of patients with the mild TBI that they're coming back from the combat in the VA system. One thing that I would love to say is you need to have at least a baseline neuropsych test for people that they experience the TBI, because during the period of time, the TBI can get worse. During the symptoms may not appear in the first few years, and then eventually would cause the cognitive impairment in general. And so what we usually suggest for people that they apply for the being evaluated, we do a neuropsych test first, and then a few years later we can repeat that one and compare it, so you do have a baseline of what was the cognitive functioning, and compare it with the one that is happened several years later. And most of the substances that you mentioned, and it was very interesting to see lots of those patients, they were using marijuana, for example, even though it wasn't significant between the TBI and the other people that they didn't have a TBI. But we know that, for example, in general, marijuana can have effect on a cognition. So if someone has a cognitive impairment as a result of the TBI and using the marijuana, would cause more damage to the total functioning at the end of the ages, when they get to the ages above 50, that would more difficulty for them to continue using their cognition to better serve themselves. And that is one of the things that is very important to educate the patient about. Yes, lots of people use marijuana, but marijuana can cause a cognitive impairment in general, and it would be bad for someone who has a TBI. Just like if someone has a diabetes and uses the lots of sugary things, it would be worse for the person who has a diabetes compared to the person that doesn't have a diabetes, for example.
Yeah, I think those are great points, especially because of the specific dysexecutive functioning that you can see, and the effects of marijuana, and how so similar a lot of those are.
That was helpful, because I often have a lot of these patients that I'll see, and then unfortunately as providers, I think we're kind of left scratching our heads at what to do about it. What comes next. I think the screening for cognitive impairment, using a team-based approach, like Mina was talking about, those are all kind of good things that we could be doing, because it's difficult. And a lot of times, I think as providers, we're sitting there looking at these patients and saying, well, I wish that hadn't happened, right? But what can we do now? So it's good to hear some of those things.
I'm actually curious, Hannah, about the screener that you cited in your references. Can you tell us a little bit more about that, like when you guys tend to use it or how you use it?
Yeah, I think it is mostly used for research contexts. I'm not sure if there's a clinical based one, but generally it just goes through and it asks, it's that table, how I said worst, first, and all that. It just makes sure that you specifically ask about each of those. So now, in clinical interviews, I don't actually pull it out, but I think it's just helpful to just remind myself, oh, I should ask about those at least criteria.
That was a big limitation that Hannah found in the literature, is a lot of the research studies and clinical settings as well just say in the intake paperwork, have you ever had a traumatic brain injury or concussion? And people just, I don't know, they skip it, they answer it however. But then when she went back and specifically asked these series of questions to try to really zero in on these experiences, the rates were very, very much higher. Because I think based off of one of their sites was the Over Mountain Recovery up the street, and their providers there had said oh, maybe 3, 4, or 5 people are saying yes to this question, and yes, only 3 or 4 people were saying yes, I've had a concussion. But then when Hannah asked it the way she asked it, it was over 50%.
Wow.
Yeah, and sometimes like my first question is very broad. It's about like, have you ever had, a really significant blow to your head? People would say no, but then when I would ask a specific question, some of them was like fell off a horse and was like had to be like airlifted and was unconscious for like a really long time. Like it wasn't even mild ones. I think it's just when people say TBI versus concussion, like I think people just have such different language for it and such different verbal abilities that I think if you can ask like very specific, very concrete questions, I think it really, really helps.
Interesting.
So Hannah, if you were to ask just like a 1 to 2 question screener, how would you, like on our social intake, how would you ask it? What do you think would be the most fruitful way in just 1 or 2 questions to get the conversation going?
Yeah, that's a really good question. Let me think. Probably just, have you ever had a really bad blow to the head? Like something very broad like that. And then I would probably give a couple examples of like, sometimes people, it happens in car accidents, sometimes it happens in sports, and just give a couple more of those that they could maybe pull from.
Yeah, because like Joyce's example with her case, right? Like this gentleman who his head slammed into the floor by an adult. Like he probably doesn't have it conceptualized in his head as like, oh yeah, my dad kept giving me concussions. But I think that's not an unusual experience, unfortunately, for kids in some of our caseloads.
Yeah, unfortunately not.
And using other terms, like a lot of people will say things like, I saw stars, or I was knocked out. So also probably sprinkling in more of like just how people commonly refer to it, because if you ask like loss of consciousness, a lot of times people, wouldn't say yes to that.
Mm-hmm. Yeah. Yeah, it's all about how in which you describe it, that they, or even just, picking up on cues from the stories that they tell you and following them down.
And I think that few sport that we know are really the cause of the head trauma can be said also during the question, have you ever been involved in, football or boxing or kickboxing or martial art or something that may cause you to have a severe head injury that can, at least cause you a severe pain or, dizziness or things like that. So using the layman language on that one, I think the best way to ask the question usually for the head trauma. Otherwise, if you use the TBI or something like that, that would not really register for the most of the patients.
And then I guess as your second question, Hannah, it seems like the loss of consciousness, like that's like one of the big severity markers, right? So if like that you can ascertain that it did happen, then do you remember the whole incident? Is there times that you were not there afterwards? Sort of how long? When did you get back with us? Is pretty telling. And then that age of when it happened, I think also is very important, correct? So if it seems like particularly this childhood trauma stuff is really worrisome.
Yeah, and so on this screener, it does a nice job of pointing out too, like even there might be some that you don't remember, but that you were told about. So thinking about early childhood ones too.
Yeah, actually, we have another client. It makes me think of that you were told about. We have another client who fell down significant number of stairs, fell down, and hit his head, and was told by family members he was never the same after that. He was like 4 or something, so he doesn't really remember it. But I know he's one that has been, he's got chronic pain stuff. He does manual labor. And I feel like sometimes our patients move amongst providers in clinic. He was mine for a while. I think he's Caleb's now. If he's still coming in, I think I heard his name the other day. Where I feel like he's had difficulty getting traction in his treatment as well. Everybody does, but there seems to be some of our patients that I do know that have had significant traumatic brain injuries. Because this gentleman's cognitive level is higher than the fellow I was telling you about before, and he gets it, but his ability to apply it seems to be very challenged. I don't know if you have anything, I think you know what I'm talking about, Caleb. No?
No, I was just thinking that, like, if this is
Yeah, he has the significant other who was in our clinic for a while. She had twins, eclamptic.
right. Okay, yeah, I was that was on my short list of people I was thinking it might be, but I actually did not know that history specifically.
Yeah,
So okay,
yeah, he did. That's where I remember very much about the story is that being told, and I'm like, is that almost like something that got put in his head at a young age? Like you were never the same afterwards? He doesn't
right.
remember what he was like before because he was, almost like pre-memory when it happened. And so that's just part of his narrative that he's glommed onto. But at the same time, in thinking about the age at which the injury occurred and just that sense of, I feel like he struggles with traction.
Less so recently, but yeah, I mean in general.
Good, good. Because sometimes it just takes time, right? Traumatic brain injury or not,
Yeah.
it takes time for these changes to start. You start to
Oh.
see the effect of the change.
Yeah. Also steady work has been helpful for him. He had bounced around job wise a lot, but has been with the same job for quite a while now. And I think that's been helpful.
Good. Good. Any other thoughts or patients that you guys have encountered or questions for Hannah? I love a long reference section, Hannah. It means I can go back and pick through it and learn even more. So thank you. And I really appreciate that we were presented with some original research today. That was awesome. So good deal. All right.
Yeah, please let me know if you have any questions about any of my research or if I can like point you to other resources, definitely.
Okay, perfect. Thank you.
Yeah, this is like cutting edge, not even published yet. It's gonna,
I know, we are
you guys
so
are seeing
lucky.
it first.
Yes, we are. I'm looking at the calendar really quick. I think I have the days in my head. Yep. The 29th of November. Good Lord, this month is already gone. The 29th of November, we get together again for our next ECHO session in 2 weeks. It's going to be about adolescence and substance use disorder. Dr. David Wood is an adolescent. He's pediatrician. He's a pediatrician who did a fellowship in adolescent, and he'll be presenting for us in 2 weeks. A very special population that presents with some special challenges. Lots of them related to the age and also related to treating substance use disorder in this age group. So he'll be presenting to us in 2 weeks, and we'll have a case to match up with that as well, where we've got an adolescent in our clinic that sort of is a good example of some of the challenges that you can face when working with a teenager who has a substance use disorder. So I want to see everybody here again in 2 weeks. Bring friends. Thank you so much, Suzanne. Welcome aboard, Jamie. It's good to have everybody who's joined us. Nice to have all of our new faces today as well. And giving you about 5 minutes back of your life. Enjoy. We'll see you in 2 weeks, everyone. Thank you. Bye.